Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Well, hello and welcome to Top Med Talk. We are here at the Society for Obstetric Anesthesia and Perinatology in beautiful Montreal, Canada. I'm Desiree, Chappell, guest hosting today on Top Med Talk, former editor-in-chief of the podcast, and I'm joined by one of the co-editor-in-chiefs currently, Professor Mike Grocott. Hi, Mike.
Good afternoon, Desiree. Fantastic to have you back in the chair.
This is our second time at SOAP with Top Med Talk. This organization is unique in that it is just for obstetrics and perinatology and for team anesthesia, but it really truly is a multidisciplinary meeting. What are you thinking so far? We're just kind of getting started, I know. But
it's great. So this is my first SOAP. It is the 58th SOAP, so it's been going a while, but it's my first SOAP meeting. Really vibrant meeting. A lot of people here, so I think maybe nearly 1,000.
I think so,
delegates.
Yeah, almost.
Big industry space, lots going on. It's a great meeting. It's a little off-piece for me. I haven't done obstetrics and
I was just going to say, when's the last time that you put an epidural in, Mike?
But I'm learning, you know?
It's never too late.
Thank you.
Just saying. So, Mike, over 800 people here. Like I said, multidisciplinary organization where they invite a lot of different types of providers. We're really lucky to have one of those teammates here with us today as our guest. It has been a long time coming that I have wanted this guest to come on Top Med Talk to tell us about her experience in obstetrics and gynecology. But we are so lucky to have Dr. Meghan MacCleary joining us.
I'm Meghan MacCleary. I'm a general OBGYN practicing out of Phoenix, Arizona.
So, Meghan, how do you end up at a meeting for obstetric anesthetists?
So probably worth putting out you as in a surgeon,
Yes.
OBGYN, obstetrics and gynecology, not an anesthetic.
That's fair.
Yeah. I'm the one who's yelling at the surgeon on the other side of the drape saying, make my patient more comfortable or put her to
Yelling
sleep.
at the anesthetist.
Yeah. Or yelling at me to go faster.
So, surgeon, been in this practicing for about how long now?
10 years?
Yeah.
Since residency, just about. Yeah.
Great.
Dating myself a little bit.
Oh, no, we're there.
The residency.
Yeah.
So, Meghan, you're here at SOAP. How did you end up as a surgeon at the meeting this year?
Almost dumb luck. Kind of started saying yes to things I wouldn't normally. And somebody invited me and I said yes and showed up. And it's been really eye-opening seeing how my anesthesia colleagues are investing in our space, which had no idea, but is really refreshing.
Tell us a little bit about your current practice.
I work at a tertiary care facility, so high risk. So we kind of see everything, high-risk moms, high-risk babies, our population ranging from normal, kind of healthy to morbidly obese. And we get, really sick with comorbid or other complications. And we do about 4,000 deliveries a year, thinking about a third of those are C-sections. So 1,200 to 1,500 C-sections, I think about annually at the facility.
That's what I was going to ask about, the rate of C-section, because I know that it has been going up, but it maybe has leveled out a little bit, or where are we at right now in kind of the U.S. when it comes to C-sections?
It's kind of very hospital dependent. It's always kind of a quality metric we're trying to drive down. Our facility, we're about 25 to 26%, which is pretty good. Different things can impact that. What's your access to anesthesia? Do you have in-house anesthesia versus, making you maybe more comfortable watching kind of the fetal heart rate tracing versus, okay, my anesthesiologist is leaving at 5 o'clock, so I need to make a decision by 5 o'clock.
So walk us through a little bit about, from your perspective as a surgeon, how do we get to the point of C-section? Obviously, we have people who may want to just repeat a C-section. Usually there's been other issues before, but walk us through a little bit about how you decide when someone gets a C-section or not.
So as I tell my patients, the big two reasons, I would do a C-section is I think it's the healthiest way to deliver the baby or safest for the baby or the safest for mom. So if the baby, based off of watching the fetal heart rate monitor, isn't tolerating labor or mom's not tolerating labor. So if she has preeclampsia or some other comorbid condition and just can't kind of tolerate the labor process, it's very physically demanding. Nobody kind of gives moms enough credit, I don't think, for what they go through during pregnancy and then that stress of labor.
Marathon that they...
Yeah. We're remodeling your entire body and then we're going to put you through like a marathon in a couple hours and then tell you to, suck it up and go take care of an infant. if it's safest for her, safest for baby are kind of the two primary indications.
Okay. And when we talk about moms now, I know this is a phenomenon that's probably not just in the US. I mean, globally changing depending on where in the world you are, but the rate of comorbidities and the complexities of moms, rates of preeclampsia, things like that, kind of level set where we are currently.
Everything is getting worse. Like especially in the US, it's where I practice. So it's kind of what I know. Your average BMI when I was in residency or kind of how heavy a mom was or comorbid conditions. Maybe she was a little bit overweight. Now, average BMI is 35. They're, class 2 obesity probably. And if I bring that to my anesthesiologist, they're happy because often they're getting class 3 obesity, or BMI is above 50. So everybody's just getting sicker. And with that comes, cardiovascular complications, diabetes, different things that make kind of the whole pregnancy and labor trickier for moms and babies.
And can you give me a flavor? I'm not so familiar with the US data. How much of that is the background comorbidity rates and how much is that mums being older as they come to you?
I would say both. I honestly can't put a number on it, but as our, average age of delivery, kind of 35 is the new 30, 40 is the new 35. And with in vitro fertilization and all that technology getting better. So patients are older, so they're sicker. They've already kind of been diagnosed with high blood pressure 5 years ago versus, okay, they're going to get it in 5 years.
Yeah. So if a mom is preeclamptic or having blood pressure issues, are they always going to go straight? This is my ignorance too, but are they going to go straight to C-section or do you try and deliver them vaginally or?
So usually the goal is a vaginal delivery because, with all the hemodynamic changes, that's going to be safest. Now, if a mom's like severe preeclamptic or I'm having to give her medicines to bring her blood pressure down or having to add another medication called magnesium, to minimize or kind of decrease her chance of having a seizure, I think her labor is going to be prolonged. We're looking at, 24 hours, if she's kind of first time mom, not in labor, and now I have to induce her. That's a huge stressful process. And sometimes the safest in that condition is a C-section. Then we're not kind of that 24 or 36 hours of stress. But most of the time, a vaginal delivery is kind of our goal.
And so when it comes to a mom that ends up having to have a C-section, whether or not it was planned or not, walk us through a little bit about what it looks like for the mom's hemodynamic changes and some of the things that you're concerned about as a surgeon during the true surgery that they're having.
I would say my concern and thought process was different. I actually had 2 C-sections, so some of the things moms, like their comfort level, I'm more concerned about now, and that's changed versus me just as a surgeon. I can kind of put my mom lens on. And so I'm worried about, is she going to be comfortable during surgery?
From pain management,
right? Okay. So kind of, are we going in, is her epidural working or is her spinal working? Is she comfortable with that? Is she going to get sick during surgery? My first C-section, I was hypotensive and threw up the whole time. And I don't remember the first 12 hours of my kid's life, And so, and that was like PTSD. Even as a 100%. Doctor going into my second one, that was the thing I was most worried about. And then obviously, I say never trust a pregnant woman because even the low risk C-sections, you're worried they're going to bleed on you. Or, my goal is to kind of have a healthy mom and a healthy baby on the table and get them off the table successfully.
So we have the comorbidities and issues going in knowing that you're kind of going to be dealing with treating blood pressure and hemodynamic instability. But there's also the phase of hemostasis and postpartum hemorrhage and things like that. Walk us through some of those concerns that you have and where we are in the space right now about recognition of postpartum hemorrhage and maybe even the rates of mortality and or at least severe morbidity with that.
We're okay at recognizing it. I think depending on our facility, our facility, we have continuous non-invasive like blood pressure monitoring. So we're a little bit advanced in that. But when we rely on some of the old standard arm cuffs, we're not great. We kind of rely on mom's other vital sign changes, her heart rate to go up, but then
how she's feeling actually.
Right. How's mom feeling? Oh, she's not tired because she's hypotensive or hypovolemic. She's tired because we just stressed her out. And so a lot of that can be kind of swept under the rug, which I think can be dangerous. Moms can conceal a lot of blood inside their uterus, before we can identify it. So I think, postpartum hemorrhage is one of the things you always have in your mind as a surgeon, immediately kind of at the time of delivery and then for the first 24, 48 hours. And then you kind of reach that and you're like, okay, great. Our risk of her bleeding is significantly less.
Yeah. And what are rates of mortality now from that? Do you know off the top of your head?
50% is a kind of, what we can predict and decrease, I believe.
You know, I mean, I think it's still a significant risk for us in the obstetric world that we still have mothers dying of hemorrhage.
Well, and the fact that the U.S., our rates are worse than a lot of the third world countries.
Yeah.
You know, especially like postpartum hemorrhage, that's our leading cause, you know, and then we have kind of all the other comorbid conditions.
Yeah.
And is that something that's widely known? Because when I first heard that, it's quite shocking.
It is. And it's one of those things. And, you know, why kind of being here at SOAP was refreshing to see like, hey, as an OB, you know, my anesthesia colleagues also care about this, and listening to kind of their involvement in it is we kind of all know about it and going through training. You know, you're taught what are the main causes of postpartum hemorrhage, but a little bit because nobody wants to do trials or bring new things, I think, into the obstetric space. Women are kind of underserved, in my opinion. And so that's why some of the new technologies haven't gotten there so quickly.
But the public, the mums-to-be, are they aware that this is an issue?
No, nobody realizes how stressful pregnancy is on the body or kind of those rates. So I would say the general public has no idea. And so when you hear those kind of horror stories of, oh, this influencer died, you know, or different things like that, it's, as an OB, you're like, okay, that tracks the story, but the public is shocked and outraged, which, if that's what it takes to move the needle, I think is important.
Yeah. I think we were shocked here when we were at SOAP a couple years ago to hear the rates of maternal mortality were worse in the U.S. than some African countries. Mm-hmm. It truly is an issue. And I think that collaboration now, it seems like what the space is moving to. And again, I'm not intimately involved or in it that much, but from what I hear here and in other meetings, there's becoming a lot more communication and realizing that it truly is not just a surgical issue. It's all of our issues to kind of help with.
And I think that's when we're most successful, right? Is when I work with you on the other side of the drape and we have this conversation of, well, what are you seeing on your monitor? Maybe I've lost more blood than I think, right? We know as surgeons, I've never lost any blood, you know, in any case I've ever done. And it's, you know, but we're not good predictors of it.
Amazing.
But, you know, it kind of, I think we need to have that open communication and teamwork in an OR and like all move towards the same goal and put our pride aside and like, hey, this is what you're seeing and what you think versus this is what I'm seeing and what I think and how can we achieve that?
One of the things that strikes me about the numbers is if you think that other comparable wealthy countries have levels of mortality that are maybe half or even a quarter. I mean, what it does tell you is you've probably got a lot of room. If you get some bits and pieces right, then there's a room to improve enormously.
Yeah, I think we can only get better or should only be getting better from here.
Yeah, let's hope.
Yeah.
So, Meghan, you talked a little bit about the fact that you feel like you're doing things, you know, you've kind of upped your game a little bit at your facility and you do things a little bit better there, that you're having more early recognition of issues, hypotension, things like that. Walk us through what that has looked like for you.
Our facility adapted this non-invasive blood pressure monitoring. And as a result, I think it's, you know, we can be more proactive and calling for a medication or calling for blood products just a couple minutes earlier. When you think about the volume of blood that goes to the uterus every minute and how quickly I can lose a liter of blood, the average blood loss for a C-section's, you know, half a liter. So, which for any other surgery is remarkable. And for C-sections, you're just thinking like, oh, I only lost 500.
Oh yeah, good.
You know, but because a lot of our patients can compensate. And so when we have these early identifiers of, okay, yes, we've lost blood. Okay, now we're hemodynamically unstable. We can be more proactive. And that makes, I think, a difference of our postpartum hemorrhage rates, our ICU transfers, kind of keeping our moms a lot safer. About a year ago, we did kind of a quality study for an improvement project for over 90 days. And we saw decreases in postpartum hemorrhage. We saw decreases in ICU transfers. When we were comparing, you know, the non-invasive cuff, non-invasive continuous blood pressure monitoring to like the traditional like intermittent arm cuff. And anybody who's been bedside knows that like your traditional arm cuff doesn't work, you know, especially when you're having to put it on somebody's leg because she's shaking or anything like that. I think when we have better data as anesthesia or team OB, better data, we're going to be better clinicians.
Yeah. So you have with the continuous finger cuff, I think it goes, you know, goes on the finger, of course, and we get continuous arterial monitoring versus like the arm cuff. And I remember from back in the days, whenever I trained in OB, if the mom was shivering, if they're moving at all, it's like you don't get it. And then also if they do have a sudden drop in their blood pressure and it's been 2 minutes or 3 minutes between, it can drop that quickly. Right. And then it takes forever because it's cycling again and the mom's already throwing up before you actually see the blood
Mom's
pressure.
already throwing up or she's moved. And so now it's been 5 or 10 minutes and like that's an eternity. You know, my C-section hopefully is done in like 28 minutes. So maybe I've had 2 blood pressures if we're just counting an intermittent arm cuff.
Yeah. So, and I think that you've said too that continuous non-invasive has really kind of changed the game in that you are able to identify hypertension more quickly, but also having the advanced parameters for cardiac output and some of that monitoring technology has helped as well.
Yeah, and we use that unless I'm using, and we also use that finger cuff like in postpartum hemorrhages. So if mom's a bleeding postpartum, we'll kind of, as we're running with the postpartum hemorrhage cart, it's part of our kind of protocols to take it with us. In an OR, relying more on team anesthesia to tell me, look at the monitor.
Yeah.
And I think, especially when you get into the EA, DYNE, and a lot of those advanced parameters, I'm going to have to dust off those cobwebs.
Yeah.
But, cardiac output, SVR, like those are the basics I can interpret. I think that, again, strikes that conversation and that teamwork. What are you seeing? What am I seeing? How's that clinically applicable? How are you going to treat it? Do we need blood? Do we need pressors? Kind of thing.
I love that true collaboration that you now have something to kind of anchor to be able to talk about rather than, I think they're hypotensive or they're becoming a little hypotensive. What's going on? Where it's more aggressive, where this now seems to be a little bit more collaborative.
Right. And you're not waiting for, can somebody put the arm cuff on her ankle or can we wait for it to recycle it? The anesthesia is like, no, I have data saying she's hypotensive or she's about to become hemodynamically unstable. So they're more confident. So then I'm more confident, like kind of elevates all of our care.
With some of this work that you've done, you participated, I think it was last year. Gosh, it seems sooner than that, but I almost says a year ago, next month in the Anesthesia Patient Safety Foundation or APSF Capitol Hill briefing. Tell us a little bit about that experience for you.
That was another just kind of you get invited to something, you say yes, and then you figure out what you're invited to. Super cool experience. And again, one of those, you're working with these people and kind of day to day, you almost feel like you're in isolation, but you seem like, no, all of these people care about my patients and we're all pushing for the big thing. And the big theme of that is continuous blood pressure should be the standard. Previously we didn't have the technology for it, and we do have the technology. Women deserve it and it deserves to be in our space. And that should become our new standard of care.
Yeah. And currently in the current guidelines, it does not say to do continuous for that as it stands at the moment.
No, depending on which guidelines you're reading, it's either cycle the blood pressure cuff every 1 minute or every 5 minutes. And then like ACOG and SMFM says low threshold to go to an arterial line, which nobody really wants to stab a pregnant woman in her wrist right before she goes for a C-section.
Yeah, exactly.
If you don't have to, like sometimes it's needed, but not if you don't have to.
Totally. So you did the APSF Capitol Hill briefing, which I think went over really well. And you becoming a voice for this and a true advocate. Tell us a little bit about, are you going to ACOG?
Yeah. So it's the American College of Obstetrics and Gynecologists. And I actually, go tomorrow meeting my husband who's flying solo with both of our kids. Bless his heart.
Fun.
Yeah. So he's the real champion, but meeting him down in DC tomorrow. And we're going to do that this weekend because it's a Friday, Saturday, Sunday.
And are you presenting at ACOG or any of this work?
No, just get to enjoy.
That's amazing. Now, is ACOG working on any changes on standards or anything that's happening in the space there? Or how is any of this work getting into your space?
So right now it's kind of word of mouth. And I think bringing it in through, partnering with our anesthesia colleagues, our nursing colleagues, and bringing that and kind of spreading awareness, because up until 2 years ago, I didn't even know this technology could exist. So as obstetricians, we need to get better about educating ourselves on the newest technology and attending conferences like this that are outside our realm.
Yeah. In closing, this is something that you use continuous non-invasive on all your patients, or do you risk stratify for certain cases, or how does that work? A C-section specifically.
So right now, risk stratify. So C-sections get them, and then postpartum hemorrhages, we have it kind of part of our kit that we can
whether
take
or not
over.
they labored or were a C-section,
So
independent of that.
I've put it on my vaginal delivery. She was a severe preeclamptic. Vaginal delivery, now she's bleeding, now she's shaking. Okay, let's put this on because her arm cuff is already misfired 2 or 3 times and I need to know what's going on. Or in triage, our obstetric ED, or emergency department, when they first come in, depending on what their blood pressure is showing, what her comorbid conditions are, it kind of gives us a nice, when the triage nurse is calling me saying, hey, I put the arm cuff on her ankle and her wrist and her left arm and her thigh. And I'm getting all these different numbers. I'm like, okay, put this on her, put the finger cuff on her, and let's see what we get. So then we know, am I admitting her for her blood pressure or am I just going to treat her headache with Tylenol?
Yeah. From an anesthesiologist, anesthetist, CRNA perspective, how do we best talk to our surgeon colleagues about the need for continuous non-invasive and get them kind of on board with what we're doing? Because I think that perspective of the surgeon's perspective is really important.
Yeah. I mean, I think it just starts with lowering the drape and having the conversation of, hey, this is what I'm seeing. You could go from the patient satisfaction, right? Hey, your patient won't be puking, so you're not dodging bowel when I'm closing fascia, or your patient's going to be more comfortable. It's going to be probably surgeon dependent, and realize we all trained not knowing this technology existed. So it's kind of changing that culture, which is hard to do, but kind of that persistence and
yeah. So whenever we're going to our administrators and those who are the ones that kind of carry the financial side of this and clinical quality as well, what are some of the things that you talk to them about the need for continuous non-invasive for laboring and C-section moms?
How we did it was we had kind of nursing on board, anesthesia on board, OB on board, and we got quality on board because it kept patients safer. So their length of stay was less postpartum hemorrhage, less ICU admissions. I think I know other facilities looking into like post-op infection rates with maintaining better hemodynamic stability. And
AKI, I think.
Right. Which there's not data quite yet in the obstetric space, I think, because it's just moving into it. But if you look in some of like the spine spaces and ortho spaces, the data is there. So I think just because it's not quite there yet in the obstetric space, it's just because it hasn't been there. And so our pregnant moms deserve to be experimented on with better quality technology.
Yeah. And like you said, patient satisfaction. Yeah. And I really interested in the bonding moments that you have. Because I remember my arm cuff going off, and it's really annoying because they're like, we got to get it because your blood pressure's low. And then you just feel like you kind of lose all that.
Right. And this mom can snuggle her baby. You're not, a new mom who had a C-section, who she doesn't want, who probably feels crappy and just got done throwing up. And now she finally gets to hold her baby. And then you're like, sorry, actually, I'm going to strap you back down and hold you. Just because your blood pressure is a little bit low and you're trying not to throw up, but like, I need a good blood pressure. And you're like, it's low. I can tell you that.
Yeah, exactly. That was my experience. But anyway, Meghan, thank you so much. This was great to talk to you. Good luck at ACOG. Enjoy it, where you can just be a spectator this year and have fun with the family. But hopefully we'll have you back soon.
Yeah. Thank you guys for having me.
Yeah. And it was fun, I promise.
Yeah.
Good. All right. And thank you for listening to Top Med Talk. You can always find us on your favorite podcatcher. We're all over social media. If you find us on YouTube, Instagram, wherever, give us a thumbs up, give us a like. All that little bit helps for sure. And if there's anything that you want to hear more about on Top Med Talk, don't hesitate to reach out to us. You can comment on any of the pods that we do. Please let us know. We are here for you. And you know what? Thanks so much for listening.
And thank you to our sponsors.
And thank you to our sponsors. That's right. To all of our sponsors who keep the lights on at Top Med Talk. And more important, keep Top Med Talk free and open access to the globe.
GE and BD.
Yes.
Thank you.
Thank you. All right. Cheers, everybody.
Bye-bye.